இல்ல இந்த பிரசன்ட் பண்றவங்க எல்லாம் கோ ஹோஸ்ட்னு போடுது. அது எப்படி அவங்க ஆட் ஆவாங்க? கேக்குதா? ஹலோ? சாருங்க ஒண்ணுல எங்க காலேஜ்ல இருந்து இவங்க பிரசன்ட் பண்றாங்க. வினோதினி அசிஸ்டன்ட்.
எஸ் மேம்.
அவங்கள கோ ஹோஸ்டா பண்ணுங்க.
எஸ் மேம், நான் பண்றேன்.
தேங்க்யூ.
மேம் டன் மேம்.
தேங்க்ஸ் a lot. Okay. சரி. வினோதினி உங்களை கோ ஹோஸ்ட் ஆக்க சொல்லிட்டாங்க, வச்சுட்டாங்க. சரியா? ஓகே அப்படி ஸ்டார்ட் பண்ணிக்கலாம். We were able to diagnose based on morphology and PAs. Neutral.
Start video இங்க இருக்கு மேடம். ஓகே ஜாயின் ஆயிடுச்சு. Thank you sir. எனக்கு அந்த இது பண்ணுங்க.
உங்களுக்கு மெசேஜ் பண்ணி
Thank you. நம்பர் நான் கொடுத்துட்டேன் மேடம். கொடுத்துட்டீங்களா? Thank you. வேற ஏதாவது கவிதா பத்தி உங்களுக்கு தெரியுமா? அதான் மேடம் just want to know the clinical history.
Hello, good afternoon, Madam Chandra, Madam. It's not yet time, 3 minutes to go. Sorry, Jana. Jana. Chandra, Madam. Here. Go. Shall we start the meeting? It's just 1 minute to go. Madam, Chandra, madam, are you there? Jamila, madam?
Yes, good afternoon. I'm here.
Good afternoon, good afternoon. வாங்க அப்பா இப்பதான் குரல் கேக்குது. Chandra madam is not yet in. So we start at, I mean, it's going to be 2. Shall we start? Shall we go on? This is welcoming you all to the 35th City Pathology Meet. We have a host, we have a number of 9 cases here. And so thank you so much for the cooperation. And so we can begin. Shall we go on with the first case? Lavanya, Dr. Lavanya, are you ready? Then you can start with the first case. Dr. Lavanya?
Yes, ma'am.
Are you ready, ma?
Yes, ma'am, I'm ready.
Then you can share that we can go on with the first case, ma. I think Stanley
Okay,
will present second or third. Can you share the screen, ma?
Yes, ma'am, I'll do.
Please.
Good morning.
ஆரம்பிக்கல போல.
Ma'am, just started, ma'am. Welcoming you, ma'am. Nice to see you there on screen.
Thank you.
Just started and just asked Dr. Lavanya from MMC to present, ma'am.
Oh, okay. நான் இப்பதான் லாஸ்ட் கேஸ் எல்லாம் படிச்சிட்டு
Jamila, madam.
ஹாய். ஃபர்ஸ்ட் கேஸ் அவங்களுதா?
First, Lavanya, can you share your screen, ma?
இல்ல. Thank you.
Dr. Lavanya? Amma, Lavanya, is there any issue? Dr. Nityanandam, if you're ready, you can share your screen. If Lavanya is having some issues, Dr. Nityanandam, if you're ready, you can press it.
Okay, ma'am, I'll present them.
Thank you. Thank you. You can share your screen.
Yeah, sure.
Hello?
Yes, ma. Dr. Sweta.
No, ma'am, I'm just checking because last time I had a problem. So I'm just checking
Okay.
whether the mic is working and all. Thank you, ma'am.
Yeah. Dr. Nityanandam,
Yes, ma'am.
please share your
Hello?
screen. You can start.
Ma'am,
Okay, ma'am.
visible-ஆ இருக்கா? Hello.
Is it visible, ma'am?
Yeah, Dr. Nityanandam, your screen is visible and I think you're audible. You can start.
Okay, ma'am.
You can put it in the slideshow mode and start.
Okay, ma'am.
அதுலயா?
Very good afternoon, everyone. I'm Dr. Nityanand from Leicester Metropolis, Chennai. I'm here to
Dr. Nityanandam, you're a little feeble. I mean,
okay.
just
Very good afternoon, everyone. I'm Dr. Nityanandam from Leicester Metropolis, Nungambakam. I'm here to present a case report, two case reports on sinonasal tumors. The first case is a 52-year-old male with a polypoid mass projecting through his nasal cavity.
Nityanandam, உங்க voice ரொம்ப feeble-ஆ இருக்கு. Just check, please.
Yes, ma'am. Give me a minute. Is it audible now, ma'am?
இன்னும் கொஞ்சம் you're very clear, but ஆனா உங்களோட வால்யூம் ரொம்ப கம்மியா இருக்கு.
Okay.
I know you should place yourself near the mic. என்ன இஷ்யூன்னு தெரியல. Just check now.
Okay. Is it audible now, ma'am?
Okay, madam, can we go?
Yes.
Okay, ma'am.
Okay.
This is a 52-year-old gentleman with complaints of mass in his nasal cavity, protruding mass. He has complaints of bleeding nasal cavity. Our histopath, we had this polypoid mass, and as you can see, here's the areas of necrosis, and it is seen in involving the nasal bone also, the nasal septum. You can see this is a high power picture. Here mostly the cells are in diffuse sheets with a high mitotic activity.
Yes.
And also some cells also we can see some prominent nucleoli or grooving like cells are seen. So with this, we thought it was a high grade lesion, but with the age, we wanted to rule out nut or sinonasal squamous carcinomas. So we proceeded with markers pan-CK and EMA for ruling out the for epithelial origin, but it turned out to be negative. And to rule out neuroendocrine origin, we did synapto and CD56. It's also turned out to be negative, as key 67 is, with the necrosis, it's very high key 67. We got around 80%. Then we proceeded with CD45. It turned out to be complete positive, with strong positivity. So with that, we proceeded with the B marker CD20 and 79A, which turned out to be negative. But with CD3 also negative, we went in for another marker, CD4, turned out to be positive. Luckily, we thought our DD was like either it is PTCL or ALCL. But with CD30 being strong positivity and ALK negative, we gave it as ALK negative anaplastic large cell lymphoma, ma'am. Moving on to the next case is a 23-year-old male with sinonasal mass here in the near the sinonasal region, and we had a lot of I'm sorry, ma'am. A lot of crush artifacts too. High power. Again, here all are small cell in sheets and monomorphic, not as pleomorphic as we said saw in previous case. But the diagnostic difficulty was the in between kind of glial-like architecture, or so we thought this could be heterotopic. We thought the usual small round with 23 years of age. We thought myogenin or all small round carcinoma, small round cell tumors such as rhabdomyosarcomas were our initial DD or E-wings. So we proceeded with myogenin and synapto and 99. It turned out to be negative. So again, CD45 was negative in this, and pan-CK was negative, and GFAP was negative. So we were literally clueless. So, but usually we do 2 epithelial markers. We EMA turned to be negative. So we were literally thinking either it could be a really epithelial tumor or any other lineage which expresses EMA positive. But we still were, this could be of lympho origin, but CD45 negative. But plasma, we did 138, turned out to be a diffuse positive, and clonality was established with kappa positivity. So extraosseous plasmacytoma was a diagnosis. Patient didn't have any other history too. So close follow-up was suggested, and bone marrow biopsy was suggested for the patient. That's it, ma'am. Thank you.
Is there an ALK negative anaplastic large cell lymphoma and
Ma'am, yes, and
I thought of maybe an extranodal NKT cell because you marked the vascularity and the cells were looking little quite bizarre.
Yes, ma'am.
Angiocentric lymphoma ஏதோ சொல்ல போறீங்கன்னு நினைச்சேன் நான். You didn't do the marker for CD3, 2 and 56 எல்லாம் பண்ணல.
56 we did, ma'am. It was negative, ma'am. And CD3 also we did. It was negative. I didn't add that in my thing, ma'am. Even that was angiocentric was our initial DD2, ma'am.
That is what when I focused, I thought it was angiocentric. And actually, you thought of other Ewings and PNET also was your DD, yeah?
For that first case, ma'am? Yes, ma'am.
First case.
Yes, ma'am. The CD99 was also negative in that case, ma'am. Since it was 52-year-old, we were mostly thinking it could be epithelial origin, ma'am. SNAC and other DDs. So it was CK negative. We didn't further go for INI, ma'am.
Okay. But it was a little tough slide only. First, I mean, every DD was real confusing only.
Yes, ma'am.
But the second case, the cells were really one focus. It looks like a glial, heterotopic glial focus was there, and then the other areas looks the cells were
actually
and
the thing was like, ma'am, this was a reactive lymphoid population, ma'am. Even the IHC confirmed it. Even we were a little confused with this. So it was a very superficial. In this area was a reactive population of CD3 and 20. Even once we received IHC, this area was CD45 negative. But whereas this area took up CD45 positive. So
the second one.
Yes, ma'am, plasmacytoma. So we are also little puzzled initially. Then we thought this could be the malt of the normal sinonasal tract. So
I also thought of that in the beginning because of the age and.
Yes, ma'am. So we thought if it was a superficial biopsy, if they are taken and this could not be a false negatively, we could have given. That's why we got a nice. Actually, outside it was reported as atypical lymphoid infiltrate, ma'am. Elsewhere,
you can't give more than that without the marker.
Yes, ma'am. Yes, ma'am. So
even and the crushing artifact like areas also is there. Maybe the technical.
But this mass was really a separate area from this leucosome.
Because you're putting all that together, no, gives it. Hence, we have to come to a conclusion. Anyway, very nice cases. Always poses a problem, sinonasal tract. We always think of lymphoepithelioma, that nasopharyngeal carcinoma was our prime diagnosis in this elderly and 2 age group,
Yes, ma'am.
Usually. Anyway, nice presentation, sir.
Yes,
How common is anaplastic ALK negative lymphoma there?
ALK negative lymphoma is a little rare only, ma'am, but compared to the ALK positive, which occurs in young and adults, ALK negative occurs in older adults, ma'am. So
any questions? Any other questions for discussion?
I just now I saw the slide. I couldn't read much anyway.
Okay, Dr. Nityanandan, that was a beautiful set of cases from you. Thank you so much.
thank you for the opportunity, ma'am. I thank MHL and also my professors who taught me in PhD Medical College. Thank you.
And Dr. Lavanya?
Yes, ma'am.
Dr. Nityanandan, you can stop your screen sharing. Lavanya, you can start, ma.
Yes, ma'am.
You can share your screen, Amma.
Ma'am, can you see?
No, I can't see your screen. Dr. Lavanya, screen,
Yes,
we can't see your screen. We can just hear your voice. Ennan parunga? Yes, sir.
ma'am, I will present it as the next phase, ma'am. I have some problem in sharing the case.
You have to. Okay, ma. Thank you, ma. Thank you. Are you ready? Dr. Vani, are you ready? Dr. Vani, you can start screen share.
Ma'am, yes, ma'am.
Dr. Lavanya has some issues, so you can proceed to the next case.
Ma'am, yes, yes,
next case she will do. So,
Dr. Impana, if you're ready, you can start.
Ma'am, Sita Lakshmi ma'am will be presenting, ma'am, another 15 minutes, ma'am.
You need some time.
Yeah,
okay.
Yeah. Ma'am will be presenting.
Ma'am, Dr. Parthiban here. Shall I present the case?
Yeah, please. Yeah, just there's some issues. So you can present the case. Yes.
Yeah.
Dr. Parthiban,
Okay,
welcome,
okay.
Dr. Parthiban.
Thank you, ma'am. Good afternoon, everyone. I am Dr. Parthiban, representing SIMS Hospital, Vadapalani. I'll be presenting a case from the neuropathology department. Am I audible?
Yes.
Yeah, okay. So we had a 50-year-old gentleman with
you're audible, Dr. Parthiban.
Okay, ma'am. Thank you. We had a 50-year-old gentleman with headache and visual deterioration. So he was evaluated and found to have a cellular, supracellular, and a paracellular space occupying lesion, contrast enhancement. The plan was transpenial excision of the mass, thinking of a pituitary adenoma, and the sample was sent for frozen section. So this was what we got in the frozen section. We did a squash smear, and you can see it's a highly cellular tumor with bizarre cells and mitosis. The background was fibrillary. So we gave a diagnosis of a malignant neoplasm and said to await for permanent sections. So these are the paraffin sections. So you can very well see there is a distinct lineage of differentiation between the left half of the field and the right half of the field. Many bizarre cells with areas of punctate necrosis here is seen here, whereas here the right half shows a monomorphic tumor with an organoid pattern and slit-like vascular channels. The high power of the same showed bizarre cells with inclusions in the nuclei, and you can see the lineage here is showing nests of cells with monomorphic stippled chromatin. And the tumor cells were arranged in diffuse sheets, and it had a fibrillary background in between. And perivascular lymphocytic cuffing was noted in the bizarre cell areas. You can see large areas of necrosis and bizarre tumor cells and microvascular proliferation, brisk mitotic activity. You can see a mitotic figure here. And then we went ahead with immunohistochemistry. So immunohistochemistry, synaptophysin was positive in the monomorphic area and CAM 5.2 was positive in the monomorphic area. Whereas the high-grade areas were positive for GFAP and P53. K67 was 30% in the high.
Yeah. Now your slide is slowly moving. Yeah.
Oh, sorry. Shall I go back again?
Yeah, please.
Yeah. So immunohistochemistry, the monomorphic area, the organoid pattern area was positive for synaptophysin and CAM 5.2. Whereas the high-grade areas were positive for GFAP and P53. So the Ka67 was high in the cellular area with a 30%, and the monomorphic area was 1%. A diagnosis of pituitary adenoma with glioblastoma was made. Markers for hormones were also done for pituitary, which are all negative. And IDH1 was done, which was also negative. A diagnosis of pituitary adenoma null cell type with glioblastoma, IDH1 wild type, WHO grade 4, a collision tumor was made. It is a rare occurrence with only few case reports so far. Postulated origin of GBM is from the modified glial cells of the posterior pituitary. So the management was complete removal of the tumor with radiation therapy. As a follow-up, we had suggested for IDH1 sequencing since the patient is only 50 years old, and it turned out to be negative. And currently he is being treated as glioblastoma with radiation and follow-up. I would like to thank my team, Dr. Gokul Rupesh, Dr. Praveen Paul, and Dr. Bhanumati Ramakrishna. Thank you.
Thank you, Dr. Parthiban, for that nice case. But how common is this? That was a combination.
Yeah, that is what even it's extremely rare. Only few case reports, so total of 9 to 10 case reports so far. So it is extremely rare. We had a difficult time because on the frozen section we didn't get the pituitary adenoma component. We had a small tissue which had this malignant tumor. So since it is a supracellular region, we didn't think of a glioma, but we just gave them a hint that it has got fibrillary background. Possibility of a high-grade glioma could be there. When the sample was received in the permanent sections only, we found out the other component, the pituitary adenoma component.
One more doubt. This patient, is it having any acromegaly feature?
No, ma'am. He had just a headache with visual deterioration and no other acromegaly features. And we did all the hormones like GH, FSH, LH, prolactin. All were negative in the pituitary adenoma too, ma'am.
Okay. I thought it could be a PRL adenoma.
Oh,
GH
yeah. PRL is
that,
negative, ma'am.
Negative. Okay. I thought
Negative.
PRL. That's omomatous calcification. It is more
Yeah.
commonly PRL secreting adenomas. That is why I thought you're going, because of the sinonasal tumor extubation is more commonly with the pituitary
Yes,
adenomas.
yes.
So I was thinking with the calcification, you are going to present with this PRL secreting.
Yeah, there was not
adenoma.
much of
That was,
calcification,
my
ma'am. The
diagnosis.
tumor bizarre cells were more, which were looking almost like calcification in low power.
Oh, maybe, but because some of them your focus in high power was giving a vague little gray black.
Yeah, ma'am.
Dr.
And
Parthiban, can we see that histopath sections again, please?
Yeah, sure.
Just go back to higher power.
Yeah.
This
So
one
this is
was
the low power and this is the high power. You can see the monomorphic component here and the high bizarre component here. This is the high power of the bizarre component.
But
This
still,
bizarre
the
cells.
cells on the 11 and 12 o'clock position looks very uniform and small and dark.
Yeah, it was actually at the junction where the both were mingling. I had taken this picture now. Maybe you can have a look at the other areas, these areas.
Yeah. Huh? Yes. The necrosis, garlanding, all that.
Yes. And you can see a microvascular proliferation with mitosis.
But those cells lining the microvascular areas also looks little uniform and round and giving a feel of pituitary lesion.
Yeah, these areas were negative for synaptophysin and were positive for GFAP.
That is very funny. No?
Yeah, I can show you the IHC also. You can see here. Synapto and CAM 5.2 and GFAP. And P53 also.
Yeah, good. Anyway, without the marker, this could not have been.
Yeah, it was really difficult, ma'am. And only with few case reports so far documented, we found it difficult to get references.
Yes. And one more thing, the glial component, how much the percentage?
The glial component was approximately 60%, ma'am.
Oh, clear the predominance. But
Yes, ma'am.
But they are giving therapy, radiotherapy and other treatments.
Yes, radiotherapy. They thought of giving temozolomide. IDH1 was negative. Sequencing turned out to be negative. So now the patient is on radiation.
Oh, there are cases with IDH1 negativity also.
Yeah.
But the prognosis is
actually, he had mild erosion of the cellular bone. Otherwise, there was we did a PET scan also. There was no metastasis to intracranial. We thought whether this could be a seeding from the intracranial, but there was no lesions within the cranium, apart from this within the glial.
Okay, but very, very rare presentation.
Yeah, very rare. So far, like 9 cases or 10 cases have been reported.
Dr. Parthiban, without the IHC, what was your diagnosis? What was your
morphologically? I thought of a glioblastoma, ma'am. That is what I thought, but the site was unusual. It was very rare.
Cells are not there, no?
Yeah, the fibrillary background, ma'am. Fibrillary background with this microvascular proliferation, palisadic necrosis.
Yeah, that part, that is the main feature of.
So, and
eye opener for a mixed. This unusual combinations do occur.
Yeah, like how tumors don't follow textbooks.
What are the other common? Dr. Parthiban, what are the other common brain tumors which can coexist with pituitary adenoma? Just for
yeah, ma'am. Pituitary adenomas can also be associated with the posterior pituitary tumors like pituitary cytomas, granular cell tumors, and spindle cell oncocytomas. Apart from that, they also can be associated with craniopharyngiomas. Even low-grade pilocytic astrocytomas have been reported with adenomas.
Okay. Okay, Dr. Parthiban, thank you for that rare
There
case.
is
And
no apoplexy features were not there.
Yeah.
Hemorrhage
Thank you,
or
ma'am.
anything. Okay.
Thank you. Thank you. No, that was your first presentation from SIMS. Thank you. Thank you so much, Parthiban. Thank you.
Thank you, ma'am.
Okay. Dr. Vani will be presenting the next case.
Good afternoon, everyone.
When there is some issue with the presentation, I think. Can we go on to the next presenter till she gets it ready? Maybe in the next case she can present. Dr. Sweta? Dr. Sweta, are you ready?
Yes, ma'am. Can I do it?
Yeah. Please start sharing.
Okay, ma'am. Hello.
Dr. Sweta, there's something wrong with the audio.
Ma'am, just 1 second. I'll try once again.
Now
is it okay, ma'am?
Something is wrong.
Ma'am, is it
Dr.
okay
Sweta,
now?
your screen is visible?
Now can you hear me?
Yeah, you're clear. You're clear.
Okay, ma'am. Yeah, thank you. So this is about a ventricular lesion, which I'm going to present now in a 26-year male who presented with complaints of seizures and loss of consciousness. He had a history of fall at home and sustained injury over the left eyelid and the right lip. Then, as a part of workup, when CT brain was done, it showed an intraventricular teratoma, which was reported elsewhere. Later, when MRI was done, it showed a T1 iso-intense and T2 hyperintense contrast enhancing.
Excuse me, Dr. Shweta, I think there's an echo there on your side. If you could just address that.
How is it now, ma'am?
Yeah. It's
I
okay.
think somebody must have had their cell phone on by your side. It has to be switched off, I think.
Madam, welcome, Madam Raji, Madam. Good afternoon, Madam.
Thank you so much. Good afternoon, Valar.
Dr. Shweta, you can continue. You can continue.
Okay, ma'am.
Yeah, now it's better.
Okay, ma'am.
Valar, you can hear me?
Ma'am, I can hear you, ma'am.
Okay, then next presentation we will do, okay?
Okay, madam, fine, madam.
Thank you.
Now is it okay, ma'am?
Yes, you're audible and your screen is...
Okay, ma'am. So sorry about that. So I'll just briefly go through again. This is a 26 male with complaints of seizures and loss of consciousness. He had a history of fall at home and sustained injury over the left eyelid and the lip. So CT brain showed intraventricular teratoma. MRI was done where a differentials of ependymoma and subependymoma were given. So this is the imaging where the arrow points towards the lesion, which was like a solid cystic lesion with some specks of calcification. So biopsy was done from the ventricular lesion. At this power, we can see that there is extensive calcification. These are the blebs of calcification. And there is a somewhat like a smear, I mean, a section, cellular sections, where the cells are arranged in a pattern of sheeted pattern. And again, at this part, we can see that there is extensive calcification admixed with the lesional tissue. Again, there's another area where there is close admixture of the lesional cells as well as calcification. There are no areas of necrosis or microvascular proliferation. So when we go to the high power, the cells look very much like oligo. There is a well-defined cell border with a regular round nuclei, and most of the cells have a perinuclear halo. And interspersed, there are thin-walled blood vessels and extensive necrosis. So basically, it looks like a oligodendroglioma with extensive calcification, no mitosis, necrosis, or a microvascular proliferation. So this is another view of the same. So this is another hyper view. So with this differentials, we had these differential diagnosis of oligodendroglioma, plenty in view of extensive calcification, young patient. Although we did not see any large cells, but even the morphology and even the presence of calcification, history of seizures, ganglioglioma needs to be excluded. Pilocytic astrocytoma, though common in the young age group, but this was kept as a last differential and immunohistochemistry was suggested. So the tumor cells showed extensive positive immunostaining with the GFAP. OLIG2 being a nuclear marker is also showed diffuse positivity. IDH1 we repeated on 2 different sections. Both of them showed negative immunostaining. ATRX showed a retained pattern. CD34 showed diffuse positivity in most of the tumor cells, and there were no spider-like cells. It is the main tumor cells which showed diffuse membranous positivity. Ki67, as expected, was low. BRAF showed diffuse positivity in the tumor cells. So to summarize the IHC, it was positive for GFAP and OLIG2. ATRX is retained. IDH1 done on 2 different blocks. Both the times it was negative. BRAF and CD34 diffuse positive. Ki67 was low. I have not put up the pictures of NEWN P53, which both of them were negative. And neurofilament showed a partial infiltrative pattern. So with this immunohistochemistry pattern, the differentials were oligodendroglioma and plenty. Ganglioglioma is ruled out because CD34 has not come as spider-like cells, and BRAF is diffuse positive. So what is it? It is nothing but plenty, which is an abbreviation for polymorphous low-grade neuroepithelial tumor of the young, CNS WHO grade 1. A few words about plenty. They have oligodendroglioma-like cellular component, infiltrative growth pattern, diffuse CD34 immunopositivity, a distinct DNA methylation signature, most commonly related to that of a ganglioglioma, and they harbor molecular abnormalities involving MAP kinase pathway. So when we did the research about plenty, we found a nice paper from BMC Neurology in 2020, where they have described cases, 3 cases, and they have given a review of literature. So in this, they have reviewed 14 cases. Most of them presented with epilepsy, and a few of them had dizziness and visual disturbances. Calcification was present, and BRAF mutation, where it was done, it was positive, though some cases it was not available or negative. And there is a fusion transcript, which is characteristic of this lesion is FGFR, that is fibroblastic growth factor. So plenty in 2016, it's a recent entity where Jason et al. Have reported a new type of epileptogenic tumor and named the entity as plenty. It is a distinct epileptogenic neoplasm which is characterized by oligodendroglioma-like cellular component and genetic abnormalities of either BRAF or FGFR2 or 3. So whenever there's any patient, especially young patient with long-term epilepsy, the differential diagnosis we think are, so these are termed as LEAT, that is long-term epilepsy associated brain tumors. So the differentials we should keep in mind are pilocytic astrocytoma, ganglioglioma, pleomorphic xanthoastrocytoma or PXA, DNET, angiocentric glioma, pediatric oligodendroglioma, and this new entity of plenty. Most of them do not share the molecular features typically observed in adult diffuse glioma, such as IDH1 or 1p19q codeletion. So this was first reported by Jason et al. And most of these had either BRAF or FGFR fusion. So how we came about the diagnosis of plenty in this, the differentials which we had were given in this table. It's not oligodendroglioma because oligodendroglioma is predominantly occurring in adults. These are either cortical or a subcortical location, most commonly seen in the frontal lobe, positive for IDH1 mutation and 1p19q codeletion. The other differentials are DNET. The similarities between DNET and plenty is both of them are cortical based and drug resistant. The differences is what they have described in the paper by Jason was plenty, the size of the lesions usually range from 0.7 to 3 centimeters, whereas in DNET it is more than 3 centimeters. And imaging also they found that soap bubble appearance was made out in DNET, whereas plenty it is a salt and pepper appearance. This is because of these patchy areas of blob calcification. So the other entity, whenever there is a young patient with seizures, is focal cortical dysplasia. So the difference between plenty and focal cortical dysplasia is in FCD, there is focal cortical thickening, blurry gray-white matter interface, and these are smaller lesions. But what they have described is FCD can be seen as a component of plenty also, though in our case, we did not find it. So the other entity is ganglioglioma. It is again a drug-resistant seizure-associated lesion, where on imaging it is a cystic solitary tumor with ring enhancement or calcification. Ganglioglioma, we should find two components. One is the ganglion cells and one is the glioma component. In our case, we did not find any ganglion cells. So ultimately, we gave it as plenty. So the take-home message about this case is it is one of the long-term epilepsy-associated lesion which needs to be considered whenever there is oligodendroglioma-like morphology in a young patient with infiltrative growth pattern, intense CD34 positivity, and BRAF or FGFR molecular studies or immunohistochemistry needs to be done for confirmation. Thank you, ma'am, for the opportunity.
What is the final diagnosis you said?
Plenty, ma'am.
Plenty, okay. What was this vascular picture? It doesn't look like a chicken wire appearance or vascularity was anything contributing?
No, ma'am, because there were very thin-walled blood vessels. There was no obvious chicken wire calcification, but interspersed some vessels were there.
But the calcification was more for the
Yes,
salt and pepper, chromatin, and the. Anyway, it's a take-home message. And rare pediatric component, the new entity, the highlighted was dysembryonic neuroepithelial departs from the neoplasm under restriction for a younger age patients. Isn't
DNET.
it? DNET.
Yeah, ma'am.
Also your DD.
Yes, ma'am. DNET also was one of the DD because any young patient with seizure history, we have to think of DNET also.
But lack of IDH mutation and intact chromosome 1p19q status. You have done any chromosomal study?
We suggested 1p19q for the patient, but actually patient went back to the hometown. So they didn't turn back.
Okay. I think this is the latest, they are under age of younger age patient. They are, this entity is, they wanted to bring out, I think.
Yes, ma'am. It was first described in 2016 only. So on a small biopsy, there is a high chance that these would go as either DNET or oligodendroglioma if immunohistochemistry is not done especially.
Yes, those days.
What was the age of this patient, Sweta?
This patient was 26 years, ma'am.
Yeah, 26 years is an adult, right? And
yeah,
you are,
young adult.
Yeah, so oligodendroglioma, your discussion said it is common in adults. It is also an adult only. It's not, see, if it, younger means I thought maybe a teenage or something like that. But anyway, it looks more like oligodendroglioma, and unless you do all these markers, I don't think you can make a diagnosis of plenty.
Yes, ma'am. It's only after immunohistochemistry because morphology, it looks very much like an oligodendroglioma only.
Calcification also is more common in oligodendroglioma.
Yes, ma'am.
More.
Yeah, so, and we will not find this much of calcification in DET, this embryo. So that is another feature which is negative.
Age, I was confused with age. That is why I asked.
No, 26 years glioma is quite not uncommon. We also see in a young age group, we do see a lot of gliomas. So,
yes, ma'am. Oligodendroglioma is the one which is commonly associated with seizures, especially in this age group with calcification and this kind of morphology. But IDH1 negative, it is one thing which is against oligodendroglioma.
That is true. That is true. That is
and CD34 positive, BRAF positive. So all these features are against it.
Okay. What made you think of CD34 to do CD34?
Because now I think this is the second case we got of plenty. So the previous case and this case, extensive calcification, young adult. On the imaging, when they give it a solid cystic lesion with extensive calcification, oligodendroglioma-like morphology. So we are definitely adding as a panel CD34 so that we don't miss this kind of lesions.
Okay. But where was the site exactly? Where was the site?
It's ventricle.
Oh, okay.
Cortex.
Not in the cortex, not in the frontal or.
In the cortex,
no, ma'am, it's in the ventricle.
Okay, that is another point.
Another problem.
Okay.
So IDH1 sequencing done?
No, ma'am, IDH1 sequencing was not done because the patient we lost follow-up. We suggested IDH1 and 1p19q co-deletion also. But patient never came back.
Anyway, it's one of the new entities. Thank you for bringing.
Thank you, ma'am.
So it's a long-term epilepsy-associated tumors. Henceforth, all these tumors we should keep in our mind in a differential diagnosis.
Yes,
thank you for throwing light on that. And it was oligodendroglioma was ruled out the mutation studies. No, is it Sweta?
Because IDH1 negativity, CD34 positive, and BRAF positivity, these are the features which is against oligodendroglioma. But still, it is only IDH1 which we do by immunohistochemistry. IDH2 we don't have IHC, but still one molecular for IDH1 and 2 needs to be done for the complete evaluation.
Is there any difference in the modality of treatment between the two? Because Ka67 is very low, you said. It's a low grade, right?
The only thing is plenty comes under grade 1 lesion, oligo comes under grade 2 lesion. So that is the only thing, but the treatment is the same. Complete excision was done.
Okay. Well, was it followed by chemo or radio or anything like that? Nothing.
No, ma'am.
No.
Because they are low grade lesions, they just kept under follow-up.
But your differential diagnosis, including pilocytic astrocytoma, I thought was far-fetched because you don't find those kind of fibers, and that histology is almost unlikely to be a pilocytic astrocytoma. Just because of the age, I think you considered that.
The age, location, and sometimes in pilocytic astrocytoma, where we see only one component, this kind of oligo-like cells can be a misleading area, because if we find the microcystic areas and the spindle cells, it is okay. But sometimes on a small biopsy, we may find exclusively oligo-like cells. So that is why I kept that in the last as a differential.
Okay.
Dr. Sweta,
Just
IDH1.
to say what are the differential diagnoses, how do we go about in a patient with epilepsy and oligo-like morphology?
Yes, that's.
Dr. Sweta, just a clarification.
Yes,
IDH1 marker was done. IDH2 marker was not done.
IDH2 immunohistochemistry we don't have, ma'am. What we have is IDH1. So that we have done on 2 different blocks. It was negative. So whenever there is IDH1 negativity, oligo-like
IDH2,
morphology.
how do we confirm? How do we confirm by fish?
By molecular, ma'am.
By molecular.
Yeah. Molecular IDH1 and IDH2. So all low-grade lesions, IDH1 negative, which looks like a oligo-like morphology, IDH1 sequencing and 1p19q co-deletion needs to be done, ma'am.
Okay. Okay. It comes under the recent review of the CNS tumors in the same grade only, no? WHO grade.
Yeah, grade 1.
Grade 1. They have revised recently, no? It doesn't change anything with this type of. No.
As far as I remember, it's grade 1 only.
Okay. Because one CME was done on the revised CNS tumors by WHO. But I don't know the latest.
Latest is also grade 1 only, ma'am.
Okay.
There is someone has sent a message in the chat box that 20 comes under pediatric type diffuse low-grade glioma in the current WHO classification. So
we have a
the pediatric type diffuse low-grade glioma under the new WHO classification. It belongs to grade 1. Okay. It's a good, very rare case.
Thank you.
Thank you, ma'am.
Thank you, Dr. Sweta. Can we go on to the next presentation, madam? Sita Lakshmi, madam, will you share your screen, ma'am?
Yeah. Impana? I hope she's sharing it. Yeah. No, this was actually, Raji will know, this was actually a e-poster which we presented. I'm audible?
Yes, ma'am. Yes, ma'am. You're audible, ma'am.
Yeah. And you can see the screen also, right?
Yes, ma'am.
The reason, we had actually presented this in the e-poster in yesterday's, Panimalar CME International. But I thought, I should share this with the pathologists, city pathologists, because many of them may not have attended the meeting or we have seen the poster because we were not given we were not selected for the first 6 posters. But anyway, this is a very, very practical point, especially when people are attached to a pediatric wing. Bicytopenia is a very, very common feature nowadays, especially when the dengue season has started and viral fever has started. Bicytopenia is a very, very common feature which we find in our clinical practice. Of course, it is defined as a reduction of any 2 cell lines. It can be RBC or it can be WBC and platelet or RBC and platelet and so on. But the commonest is leukocytes and platelets. Now, what helped us in the diagnosis of these bicytopenia was mainly the bone marrow study. So we thought we will definitely stress the importance of doing a bone marrow, especially in case of bicytopenia, which is, prolonging despite all your treatment as well as your investigations. We had a series of cases. We have taken 3 cases only from that. And the first case was actually an elderly person, not elderly, a middle-aged person, 43 years, a female, who presented with the severe macrocytic anemia and a marked thrombocytopenia with a mild leukocytosis. And despite all our treatment for the bicytopenia, it was persistent. And the clinician felt that we should go ahead with bone marrow. Being a 43-year-old lady, we should go ahead with the bone marrow, and the bone marrow was done. And here, of course, it was a suppressed trilineage hematopoiesis with bone marrow. The picture may not be very, very clear unless you have a very big screen. Now, in between the marrow trabeculae and the marrow components, you can find tight clusters of fairly uniform type of cells, which you see normally in a breast cancer. You have seen the so-called carcinoma simplex or, atypical ductal hyperplasia, where you have a compact, dense hyperplasia. You had clusters of almost very similar looking cells. And so we were thinking why it should, it was not appreciable in the marrow aspirate, but it was very, very clear in the marrow biopsy. So we went back and asked the clinician and the patient. Then we came to know that she underwent a mastectomy for a breast cancer so many years ago. After so many years and after getting her chemotherapy, she presented with persistent bicytopenia. So then we went ahead and did IHC and everything was positive. CK7 was positive, ER/PR was positive. So we concluded that it is a metastatic breast carcinoma with the persistent pancytopenia in the peripheral smear. And maybe the chemotherapy that she had undergone was the reason for the macrocytic anemia. The other two cases were young children. One was a 3-year-old boy who came with very low hemoglobin. Actually, I would say rather it is a pancytopenia because his hemoglobin was 4.8 and WBC was 4.1 on the lower one, and the platelet count was very, very low. And all the viral markers were done, they were all negative. But what we found in the peripheral smear were atypical lymphoid cells, which looked like not in conformity with a typical blast. So we called it an atypical blastoid cells, which formed nearly 31%. So we felt that we have to go for a flow as well as we have to do a bone marrow to rule out any type of leukemia. So then that played the dividend, and you can see the second smear where it was almost 100% filled with blast cells. And then we did a flow on Kala positive and fish hyperdiploid ALL was the report of fish. And there are a lot of, I'm not going into the discussion part of it because there are a lot of case histories where a bone marrow with the atypical cells in the peripheral smear has shown all types of leukemia, and AML was and ITP were the other two important diagnoses made by bone marrow study. The third case was much more interesting in that it was a young female, 6-year-old female with again a low hemoglobin of 7.9 and a WBC of 6.5, and the platelet was only 3,000. It was very, very alarming. And so we repeatedly the smear, and there was a persistent pancytopenia in this patient also. It was a microcytic hypochromic anemia with a very severe thrombocytopenia and a lymphocytosis of 92%. So we definitely advised bone marrow, both biopsy and in the aspirate. The aspirate smear, when we saw, where there was not even a single megakaryocyte. We were perplexed because even in a hypocellular marrow, we will definitely find some kind of a megakaryocyte picture, but we never found. So this is what is called as an amegakaryocytic thrombocytopenia. In any child with an amegakaryocytic thrombocytopenia, one should think of bone marrow failure syndrome. So that necessitated a trephine biopsy, and you can see the trephine biopsy for yourself. It is definitely an aplastic marrow, and even in the marrow components, we did not find megakaryocytes. So there was a marked lymphocytosis, and we did a DNA breakage analysis, which was negative for a Fanconi's anemia because that was one of the differential diagnoses. So this is definitely a case of a bone marrow failure syndrome. So mainly I wanted to highlight the importance of bone marrow examination in any case of persistent bicytopenia or a pancytopenia, even after your viral markers are negative and all your other laboratory investigations are negative, we should go ahead with the bone marrow. That will definitely help you to find out the diagnosis. And of course, we have quoted all the references and discussion, which I'm not going ahead with that. That was the main reason. And many people here, we do come across bicytopenia very often in our lab. Every day we see. But, some cases definitely require a bone marrow examination, and that you should insist to the clinician to go ahead with a bone marrow examination for you to have a definitive diagnosis. That was the main reason why we presented this.
Very nice case. And we have been getting all this, our pancytopenia cases, the marrow, and with the thrombocytopenia was very severe in 2 of the cases. We thought it is a case of dengue, but later on the marrow we did, and it turned out to be a CLL1. One is a younger patient with ALL. And your case, Sita, could it be selective aplasia or hypoplasia with the TAR syndrome?
No selective hypoplasia. The child is going for a bone marrow transplant. The father is going to, I think father HLA match was only not matching. So they wanted a donor. They're waiting for the donor. She is going ahead with the bone marrow transplant. So, and normally whenever we have a thrombocytopenia persistent with other parameters fairly normal, everybody will think of ITP, immunothrombocytopenia.
We thought of those cases.
But that is the most important point to remember. In a bone marrow aspirate or in the smear in an ITP, you will find megakaryopoiesis is increased along with the dysmorphic megakaryocytes. Whereas here, it was a total absence of megakaryocytes. That was what was thought of, and that in a bone marrow failure syndrome of aplastic anemia, this type is called as the amegakaryocytic thrombocytopenia. So that is the main reason why. So in any case of a persistent thrombocytopenia in a young child, we always think of ITP. But in an ITP, this is not the finding. So that is very important. Anyway, bone marrow examination is definitely indicated in any case of suspicious ITP.
Yeah, that is what being practiced here.
Ma'am.
Anyway, very nice.
Ma'am, so that was a very nice point, ma'am, for highlighting that cytopenias and the necessity of which.
Vani.
Thank you for highlighting.
Ma'am, shall I start presenting, ma'am? Dr. Lavanya.
One minute, ma'am. Just hold on.
Yes, ma'am.
Lavanya, the next case. Chandra phone எடுத்துன்னு கொஞ்சம் வர சொல்லுங்களேன்.
Dr. Lavanya?
Yes, ma'am.
Screen. Just a minute, ma'am.
Shall I start, ma'am?
Dr. Lavanya, you can share screen. You can share your
ma'am. Yes, ma'am. Good evening, ma'am. I'm Dr. Lavanya, Assistant Professor, Institute of Pathology, ma'am. I'm presenting a case of 27 years female, a right hepatectomy specimen. From cutting open the specimen, 12 cross 10 cross 7 centimeter lesion in the 5, 6, 7, 8 segments of liver was found. Our history was no history of hepatitis previously, no history of OCP intake. Our serum AFP levels were normal. This is the gross specimen we received. There is no capsular breach. On cut section, it's a fairly well circumscribed solid and cystic lesion was found, which was measuring 12 cross 10 cross 7 centimeter. This low power view showing the liver with an fairly circumscribed neoplasm. This is another view. The neoplasm is arranged in lobules, nest, and focally in micropapillary pattern and sheets also. The cells, the tumor cells are large, polyhedral, with clear, vacuolated, and eosinophilic cytoplasm, and a vesicular nucleus with dispersed chromatin, and some showing conspicuous nucleoli. This is another view showing the cellular details. There are large cells which have a clear to pale to eosinophilic cytoplasm and a vesicular nucleus. Some nuclei were showing clearing and some showing intranuclear inclusions. Conspicuous nucleoli was also seen. This is another view for the describing the cells. And some foci show intracellular brownish black pigments. So with this, the differentials we thought, could it be hepatocellular carcinoma? So we proceeded with the hepatocellular IHC markers. Hep bar was negative in the tumor cells. The internal control hepatocytes were positive. And we did Glypican, which was negative. HSP70 showed a focal positivity, weak positivity in focal cells, few cells. And again, CD10 did not show the canalicular staining pattern, which was observed in HCC, but not seen in our case. And CD31 also negative, which doesn't show the entrapped tumor cells, endothelial cells entrapping the tumor cells. So, hepatocellular carcinoma was ruled out. Then could it be a metastasis from any other epithelial tumors? So pan-CK we did, it was negative. CK7 and CK20 negative. So CK7, CK20 positive tumors also ruled out. Then could it be an epithelial gist metastasis? So we did DOG1 and CD117, which was negative. So metastatic renal cell carcinoma was thought of. So CD10 we have already done for HCC also, and here also there is no cytoplasmic positivity negative, and RCC was negative. Some of the papillary RCC exhibit AMACR. So AMACR we did, it was negative. So we have to rule out other tumors with large cells, large polyhedral cells with clear cytoplasm. So we did vascular markers 31 and 34 negative. SMA was negative, and neuroendocrine markers synaptophysin and CD56 were negative. So as there, it was a tumor with showing large cells with large nucleoli, some showing conspicuous nucleoli, and some foci were showing intracytoplasmic brownish black pigment. So we thought a rare possibility of malignant melanoma. So we went ahead with HMB45, Melanie, S100. HMB45 was positive in moderate positivity, showed moderate positivity in 60% of tumor cells, and Melanie, S100 were negative. So we were little hesitant to sign out as malignant melanoma, where only one marker was positive. So we wanted to, we discussed the other HMB45 tumors, positive tumors. So the first one came as the PCOMA, which is a very rare tumor. So PCOMA, there were melanocytic markers and myogenic markers. So HMB45 is the most sensitive marker for melanocytic marker in PCOMA. So in our case, HMB45 was positive moderately in 60% of tumor cells. And again, Melanie and S100 were negative. And we did the SMA and Desmin also. So both were negative. So only HMB45 was positive. So we went through the literature. There is an entity in PCOMA, that is subclassification, that is the PCOMAs which were negative for myogenic markers. There is one TFE3 translocation associated PCOMAs that will be that will show immunoreactivity in IHC itself for TFE positivity. So we did TFE3, which showed diffuse strong nuclear positivity in more than 90% of tumor cells. So TFE3 rearrangements are characteristic of alveolar soft patch sarcomas, XP11, that is translocation associated renal cell carcinomas, and other rare tumors like PCOMA. So we have HMB45 positive in 60% of tumor cells and TFE3 positive in 90% of tumor cells. So considering these TFE3 positivity, rearrangement positivities, so alveolar soft patch sarcoma, in this patient, there is no other tumors or swelling in the extremities as well as deep-seated retroperitoneal tumors were not there. And alveolar soft patch sarcoma is again HMB45 negative and Desmin positive. In our case, there is only HMB45 positive and Desmin was negative in our case. So we ruled out alveolar soft patch sarcoma. Also, translocation associated renal cell carcinomas, CTKUB, the patient was evaluated and CTKUB showed up there is no mass in the kidney. Also, HMB45 is negative in translocation associated renal cell carcinomas. So, PCOMA is the only option left out. So, coming to the discussion of PCOMA, it is mesenchymal neoplasms composed of perivascular epithelioid cells with a distinctive epithelioid cell morphology that is closely associated with the blood vessel cells. They express both melanocytic and smooth muscle markers. It is a very rare subtype. It is a very rare tumor of mesenchymal origin, most commonly associated with the females and young age group. So our patient is a young female, 27 years female. Mostly it is sporadic and a small subsets are associated with tuberous sclerosis. So the pathogenesis associated with PCOMAs are loss of heterozygosity involving the tuberous sclerosis 2 locus gene was found, deletion of 16p also associated with this PCOMAs, and TP53, a small subset of PCOMAs harbor TFE3 gene fusions, which correlate with strong nuclear immunoreactivity for TFE3. So in our case also, TFE3 was showed diffuse strong positivity in 90% of tumor cells. So this TFE3 rearranged PCOMAs lack other mutations and loss of heterozygosity. So it is a pathogenetically distinct variant of subtype of PCOMA. So grossly, they are well circumscribed with a firm to fleshy cut surface. And microscopy, it is typically have a nested or lobular architecture, and a micropapillary architecture is also observed, and nest and sheets also observed. The cells are large with abundant granular eosinophilic cytoplasm, and some may show multinucleation with limited pleomorphism also. So this PCOMA comes under the tumors of uncertain malignant potential. But American Journal of Surgical Pathology, they give a specific criteria for this classification: benign and uncertain malignant potential and malignant tumors. So based on size, necrosis, and atypia and infiltration, the tumors are again classified as the non-gynecological specific criteria has been assessed by the American Journal of Surgical Pathology. So based on this, benign tumors of uncertain malignant potential, malignant criteria has been given. Our case was more than 5 centimeter. It was 12 cross 10 cross 7 centimeter and showed moderate to high grade pleomorphism, and the mitosis was more than 1 per 50 hyper field. So ours has a malignant potential. So PCOMAs with TFE3 rearrangement tend to occur in younger patients with alveolar growth pattern and often lack expression of smooth muscle markers. So all these correlated with our case, and finally signed it out as PCOMA, which is a very rare case of liver. Around 20 to 30 cases have been reported so far in the liver. Thank you, ma'am.
Can I see the picture once again, ma? Histology, what you have shown. Can you focus again, if you don't mind? Because it didn't. Difficult to. Sorry. HND. One more, the previous one. Before.
Low power view. You show us the low
Low
power
power view. Like
Yeah,
an
see.
alveolar pattern is
Actually,
there.
yeah, exactly. When I saw this, the first slide, I thought of alveolar
Yes,
soft
ma'am.
pot sarcoma.
Ama.
Exactly,
This
it's
was
right.
an
Same like
alveolar
that.
growth also.
HMB வேற இது பண்ணனால clear cell
Is it primarily from the liver?
Yes, ma'am. Primarily
Dr.
from liver.
Lavanya, is it primary in the liver?
Yes, ma'am. Primary in liver.
that is
What is the
intrahepatic,
cell of
that
origin?
is bile duct origin, could it be?
What is the
Form of
cell
the
of
bile
origin?
duct?
What is the cell of origin, ma?
Ma'am, it's a mesenchymal tumor. So around the blood vessel. So the origin is as any other site, the picomas they do from the mesenchymal origin, it is be the cell of origin.
Anywhere, bladder, everywhere. It is.
Yes, ma'am. Most common site is uterus. Most common site is uterus. They have mentioned in literature, ma'am.
How did you rule out alveolar soft pot sarcoma?
And
Doctor?
biomarker.
Only by IHC.
Yes, ma'am. Alveolar soft pot sarcoma, they are HMB45 negative, ma'am. Desmin positive.
Yours,
And
your
also
case?
patient doesn't have.
Your case?
In our case, HMB45 was positive in 60% of tumor cells. Ma'am.
Positive.
With that only we proceeded. We narrowed down the differentials and we proceeded with HMB45 tumors. Again, we came down, narrowed down to 3 diagnoses: PCOMA, alveolar soft pot sarcoma, and our first differential was alveolar soft pot sarcoma. Then translocation associated RCC. Then we came to PCOMA. Also in alveolar soft pot sarcoma, HMB45 is not expressed. Desmin will be positive and MyoD1 will be positive. And TFE3 will be again positive. So in this case, HMB45 was expressed and TFE3 is expressed. And when went through the literature, the literature says the picomas, the variants of picomas, it is a small subset of picomas which are TFE3 mutated will express strongly TFE3 IHC, and they will be myogenic markers like MyoD1 and Desmin SMA will be negative.
Dr. Lavanya, alveolar soft pot sarcoma, you'll have MyoD1, myogen, and all that will be negative, Dhanama.
Ma'am, there HMB45 not be
confusing.
HMB45 will be negative, agreed. 45 will be negative, agreed. But உங்களுக்கு அந்த muscle markers negative தான இருக்கும். MyoD1, myogen எல்லாம் negative தான இருக்கும்.
இல்ல ma'am, Desmin will be expressed and MyoD1 will be expressed.
But site of the alveolar soft pot is site on the liver.
Site will be most commonly in the extremities.
Extremities.
Yes, alveolar soft pot sarcoma is extremities, ma'am. And also the literature says, ma'am, this TFE3 mutated picomas, they typically have an alveolar growth pattern, alveolar pattern in the microscope. Where which our case had alveolar pattern. It's a big lesion, ma'am, 12 cross 10 cross 7 centimeter. We had this picture. This view shows the alveolar pattern, also lobules, nest, micropapillary pattern also seen.
Anyway, this bile duct origin, if you have to prove, then the presentation of the picoma from the liver can be justified, I feel. I don't know whether.
They have to prove that it is primarily from the liver. That is one thing. And what is the treatment modality for this?
Ma'am, complete surgical excision and follow-up is the treatment modality, ma'am. The right hepatectomy specimen was done and the margins were negative, and the patient has been kept in follow-up because it is coming under the malignant, as per the American Journal of Surgical Pathology. The site is exceeding more than 5 centimeter. There is necrosis. So atypical mitotic is also seen. So the patient is under follow-up, ma'am.
Chemotherapy?
No chemotherapy has been started. She is under follow-up.
How is the patient doing now, ma? Since this was a 21 slide.
Yes.
Now, how is the patient?
The patient, the hepatology Ma'am, our Institute of Hepatology have published this case in the international journal, ma'am, and they are following the patient. When I asked the assistant professor in hepatology, he said the last 6 months she is not in she lost the follow-up, but before that she was okay. She's doing well with the Marcus.
Okay, Dr. Lavanya, any more for discussion?
You can have the block and do the marker for bile duct and tell us in the next meeting. The
Okay, ma'am. We did CK7 and CK19 and CK7, CK19, CK20 we did, ma'am.
Okay.
And pan CK also negative, ma'am.
Oh, negative. Oh.
Yes, ma'am. 7, 20, 19 negative, ma'am.
Lavanya.
Yes, ma'am.
Dr. Mukul, in Rela Institute, our hepatopathologist is there.
Yes, ma'am.
Mukulvich.
Yes, ma'am.
You could have asked him, you could have taken his opinion also, because he is now the president of some Southeast Asia.
Ma'am, before.
I thought
yes, ma'am.
Here, he's not joined here, and even Gauri is not there. Okay. Lakshmi Priya is also not there. None of them have joined. Otherwise, you could have just taken one more.
Yes, ma'am. We got a second opinion from another corporate hospital. We got a second opinion before signing out the. We sent the blocks also, ma'am.
Okay. What did they say?
They said actually with their help we went to this line. After that only we went for TFE3.
Yeah, Mukulvich is internationally acclaimed hepatologist.
Sure, ma'am. Sure, ma'am. We'll get that.
Have taken his opinion. Oh, anyway,
we have sent the blocks to another institution and got second opinion, and finally we.
Okay, ma'am.
Yes, ma'am.
Anyway, thank you. Nice, eye-opening. We have to read PCOMA a little more extensively.
Yes, ma'am. Thank you, ma'am. Thank you so much.
Thank you, Dr. Lavanya, for that.
Thank you, ma'am.
Ma'am, madam. I'll tell you, madam. Now Dr. Vani will be screen sharing from start.
Okay. Thank you.
Dr. Lavanya, you can start. Thank you.
Yes,
thank you, madam. Thank you, Padmadi, madam, and Dr. Lavanya for that presentation from MMC. Dr. Lavanya, you have to stop screen sharing that.
Confusion in the
Hello.
Hello, madam.
Shall I start?
Yes, madam. Please.
A very good afternoon to all my fellow pathologists. So regarding the case which I'm going to present, a short history. This was a 54-year-old man who had a polytrauma in the United States, where he underwent a lot of procedures, including he had fractures of multiple bones. He had soft tissue injury. There was blunt injury of the abdomen, injury to the liver. Then there was also a presentation of intestinal obstruction. So multiple complications with polytrauma he presented 1 year back, following which he underwent history. There was a history of multiple laparotomies and colostomy, partial colostomy, and ileocection. So currently, the patient, the last procedure he underwent here in our hospital was the patient underwent a surgery for ileostomy closure, and the incidental finding was found out in the mesentery, and the samples were sent to us for histopathological examination. So this was the preoperative finding. Here you can see the mesentery shows white, firm, and bony hard areas. So not only single was there were multiple pieces embedded in the mesentery, which was excised and sent to us. So this shows the surgical, how it was removed. So it was stuck onto the mesentery. They had to cauterize and remove it. So they were all curvilinear and small pieces resembling small rib-like structures. So regarding the histopathology, the following were the findings. So we received bony hard fragments measuring 5 centimeters in toto, and it showed a portion of mesentery with dense fibroblastic proliferation admixed with inflammatory infiltrate. And this was a prominent finding, which showed a mature lamellar bone predominantly with focal osteoid production, and it was rimmed by osteoblasts, which do not show any atypia. So in this focus, you can see some multinucleated giant cells admixed with spindle-shaped cells. So this picture, you can see the advanced stage of the disease, where you can see only mature lamellar bone, and you can see enclosing fatty elements. So this is a higher magnification of the same, where you can see the mature lamellar bone with benign osteocytes enclosing the mesenteric fat. And here you can see pieces of mature bone inside the fat. So with this finding, I have not come across any mature fat. They were very sure it was a mesentery. I asked them whether there were bony fragments which was enclosed during trauma or anything. I asked a detailed history. The clinicians gave a detailed history and said this was nicely seen within the mesentery as well as in the omentum. So thinking about various intra-abdominal calcifications, you can see the common sites where you can see the calcification are the peritoneal, retroperitoneal, or in specific organs. You can see in the vessels, blood vessels, or it can be in the musculoskeletal region of the abdomen. So all this can be traced using imaging, where you can localize where the calcification is. So in our case, it was predominantly in the mesentery, and it was also in the omentum. So the imaging showed tiny specks and some large chunks of bony tissue, which was seen predominantly in the mesentery. So to think about what are all the causes for abdominal calcification, the common causes include recurrent cases of peritonitis, recurrent dialysis patients, ovarian malignancies with the stomatitis of calcification, large soft tissue sarcomas with areas of necrosis and calcification, tumor necrosis with the calcification, adrenal calcification, which can follow recurrent hemorrhages in the adrenal or following trauma. So in our case, we had a clear-cut history. So this condition was termed as heterotopic mesenteric ossification, otherwise called as intra-abdominal myositis ossificans. So we usually see cases of myositis ossificans in the soft tissue following fracture of long bones, which is a very common thing. And the pathogenesis of myositis ossificans in the soft tissue is the same as that seen in the mesentery, where it is thought that the fibroblastic proliferation transform into osteoblasts as well as chondroblasts and give rise to this form of heterotopic ossification. So the pathogenesis is going to be the same, but the site only is rare. And cases of ossification reported in the mesentery in the literature says only less than 20 cases have been reported. So the case is being just presented for its rarity. Coming to the discussion, heterotopic ossification is development of bone at extraskeletal sites. You can see the various stages or zonal pattern depending upon the duration of the lesion. So in the early stages, it will be immature bone. In the later stages, they will form lamellar bone. So it is also called as intra-abdominal myositis ossificans or mesenteritis ossificans, and is usually associated with abdominal trauma and recurrent surgeries, especially repeated laparotomies, as we saw in this case. And the classical zoning phenomena of immature osteoid surrounded by maturing osteoid and osteoblast going on to mature lamellar bone can be identified, as we saw in this case. Thank you.
Jamila, where is the zonal phenomenon? I didn't appreciate any zonal phenomenon.
Madam, this case in a, Madam, the slides.
Why can't you go just a simple metaplastic osteoid? See, osseous metaplasia is very well known in so many areas, and especially when you have so much of I won't say morbidity, but he had undergone so many surgeries and infections. So definitely metaplastic osteoid can come. What is the difference?
Madam, one point I want to say is when you see predominantly mature lamellar bone, it only indicates a stage of myositis ossificans. You need not see all the stages in all the cases. In some stages, it may be an early stage where you see only predominantly fibroblastic proliferation, which progresses to osteoblastic proliferation, then immature, then osteoid, then the final stage you see lamellar bone. The pictures which I had projected for this case was predominantly lamellar bone. But the other areas which I saw, all the stages were seen very well.
Ma'am, I would like to agree with Jamila. The reason being that the literature also states that depending on the stage, in the late stages, you don't see the zonation at all, and it becomes a lamellar bone. Maybe in other sites, you can see some cartilage and things like that. You need not have full, the entire spectrum of this zonation need not be there, ma'am. I do agree with Jamila for that. Even in an elbow injury, you don't get to see the...
Raji, they had said in their discussion that the zonation phenomenon was observed, but we didn't observe it in the slide that she projected. That is what I was trying to point out.
Yes, ma'am.
Madam, the one point which correlated with my diagnosis was most of the references had polytrauma and multiple laparotomies, which correlated well with this case.
No, my only question, Jamila, is how do you differentiate this from a metaplastic osteoid? You say it is a heterotopic ossification.
Yes, madam.
What way that is different from a metaplastic osteoid?
Madam, metaplastic osteoid, you commonly seen in which conditions, madam? Only in tumors.
Most of the inflammatory conditions, when you have...
But there was no inflammatory component. Madam, there was no inflammatory component in this patient. There was no tumor pathology in this patient. There was it was not related to any organ. So we had to rule out all the other conditions, and then only arrive at this diagnosis. Inflammatory was ruled out. There was no.
Okay. See, it is a metaplasia always occurs, as a slow process. So this he has been having it for almost so many laparotomies, so many things he has undergone. So possibility.
That only predisposes, madam. That only predisposes to the heterotopic ossification.
Okay.
That is a causative factor for this condition in this patient, particular patient.
Okay.
Okay, madam. Thank you for that discussion, and that was a nice presentation, madam. Thank you so much. Can we go on to the next presenter, Dr. Vani from Stanley? There are two more presentations. If they could get ready after this, we can have those. Dr. Vinodini from Thiruvannamalai Medical College and Vadalkani. Two more presentations. Yeah. Dr. Vani, you can start.
Good afternoon, ma'am. Am I audible? This presentation is going to unveil the intriguing components of kidney's hidden chamber. And the case report was 65 years old female presented with complaints of headache, and a multi-slice CT brain was done. It shows a well-defined soft tissue lesion measuring 4.2 cross 3.7 cross 2.8 in the posterior cranial fossa, which infiltrated into the occipital bone and caused lysis. The impression given was metastasis. Then CT thorax was done, no significant abnormality detected. And they proceeded with the contrast enhanced CT abdomen and pelvis. It showed a well-defined, irregular, complex cystic and solid mass lesion of 7.5 cross 7.2 cross 8.3 in the mid and lower pole of the kidney. And the impression given was renal cell carcinoma or multilocular cystic nephroma. Then MRI KUB was done. It shows a lobular exophytic solid cystic mass lesion in the inferior pole of the right kidney, measuring 6.1 cross 6.1 cross 6.7. And the right renal inferior segmental branch is not visualized, likely to be a tumor invasion. Then this is the para picture showing a cut surface of the kidney with a mass of variegated appearance. And we received right radical nephrectomy specimen measuring 13 cross 9 cross 5 centimeter with attached perinephric fad of fat and ureter measuring 3 centimeters in length. And externally capsular breach was noted. And the cut surface of the kidney shows a variegated solid and cystic mass, which shows necrotic friable areas, cystic areas, and gray white solid components. And the tumor was seen abutting the renal sinus. And on microscopy, multiple sections were studied and it showed varied patterns. This picture shows the papillary pattern with the central fibrovascular core lined by pleomorphic cells. And this shows the core, papillary core with foamy histiocytes. And this picture shows the papillary variant with cystic change. And another foci shows the tumor arranged in nests. Tumor arranged in nests and sheets, and cells are with a clear to eosinophilic granular cytoplasm separated by a thin fibrovascular septa. Then sarcomatoid areas were also noted. And another foci showed a tumor with ducts glands within a desmoplastic stroma. This is the hyper view of the same, showing glandular pattern, tubules and tubulopapillary pattern lined by highly pleomorphic cells. And this picture shows intraglandular micropapillary tufting. And this shows micropapillary tufts. And also seen are cholesterol crystals and microcalcifications. And hemosiderin deposition was seen with a sclerotic stroma. And one foci shows rhabdoid areas also. And this picture shows the involvement of renal sinus and the fat. And areas of necrosis were also seen. And adjacent kidney showed interstitial edema, tubular atrophy, dense inflammatory cell infiltrate with hyalinization and thyroidization of tubules. Then we proceeded on with immunohistochemistry. CK7 and CD10 found to be negative. And Amaker showed a nice cytoplasmic positivity, and Paxate was positive. And GATA3 showed negativity. INI1 was done, and it showed INI1 is retained. And CK19 was done. CK19 showed cytoplasmic and membranous positivity. And these are the positive markers. Amaker was positive in papillary areas. This favors papillary carcinoma, and CK7 negativity and Paxate favors clear cell renal cell carcinoma, and INI1 retention and CK19 positivity favors collecting duct carcinoma, and GATA3 ruled out urothelial carcinoma and TTF1 lung carcinoma. Then we signed it out as renal cell carcinoma, NOS, with the following components: clear cell renal cell carcinoma with sarcomatoid and rhabdoid features, papillary renal cell carcinoma, and collecting duct carcinoma. In recent WHO entities, there is no special mention about the composite tumors, and so it is signed out as renal cell carcinoma, NOS. Then a few words about the renal collision tumors. And the collision tumor is 2 or more unrelated tumor types at the same location, forming a single lesion. The tumors will be limited. They do not undergo tumor changes. Whereas in composite tumors, different tumors in the single location, they don't have clear limits. They undergo tumor changes. And synchronous tumors are tumors of different types in different locations within the same organ. And few words about the histogenesis of this composite tumors. 2 distinct cell lines after a common oncogenic stimulus can cause 2 tumors with different phenotypes. The other one is first tumor could alter the organ's microenvironment and cause the second tumor to have a different phenotype. Or a common precursor stem cell can differentiate into 2 lineages causing 2 tumors. 2 distinct tumors in the same anatomical site could have arisen accidentally after a different oncogenic stimulus, but the histogenesis is still controversial. And the plan for this patient, our patient is, she went on for cerebellar metastasis. So even the radical nephrectomy is of no use except for palliative purpose. So PET-CT was planned and palliative whole brain radiotherapy for cerebellar metastasis, followed by systemic therapy with pasopanic was planned. And coming on to conclusion, the tumors which are composed of 2 or more distinct types of renal cell carcinoma are very rare, and histological diagnosis is challenging, and it requires extensive sampling of tumor components. As this entity is very rare and the clinical impact has not been still clearly established, the management is based on the standard guidelines for classic renal tumors. And histogenesis is also still controversial, and the prognosis depends on the nuclear or grade or stage of the most aggressive component. And I would like to thank my HOD, Professor Arunlatha ma'am, and my acknowledgements to Professors Dr. Ali Sumitra Devi ma'am, Professor Valarmadi ma'am, and my colleagues Dr. Balamurugan and Dr. Arun. Thank you.
Did PAX8 was good, ma?
PAX8 was positive.
Positive.
This case was presented for its rarity, ma'am. Usually we have only papillary carcinoma and clear cell carcinoma. We have only 2 different histological types. Here, it was an array of histological types. We had the clear cell component, the sarcomatoid, we had rhabdoid features, papillary areas, and collecting duct areas. So since it was a multiplex of different varied histologies, and we couldn't place it now, the composite, it's not, the term composite and collision tumors are not in our latest WHO guidelines, ma'am. So it is just that even if you have a multiplicity of all these histopathological entities, we just call it under the name renal cell carcinoma with renal cell carcinoma NOS. It was presented because we had, it was of histopathological interest. We had different features of the same lesion, ma'am. That's why.
But the collecting duct carcinoma also with various pattern you can have with sarcomatoid features.
Yes, ma'am. The collecting duct component was there with the micropapillary areas, and we had the clear cell component, we had the rhabdoid areas. So it's because of varied histopathological entities occurring in the, we haven't seen, when we went back to the literature and saw, we hadn't seen all this multiplicity, so many histopathological types occurring in the same tumor, ma'am. So for the treatment sake, it is just taken.
Usually collecting duct carcinoma is a diagnosis of exclusion.
Ma'am, we had done IHC to confirm that we had beautiful that areas, ma'am, that histopathological. We had nice glandular areas there. Glandular areas with micropapillary tufting, and so it was a straight we had to take multiple bits from and it required extensive sampling. So because each area showed a different variety of tumor. In one area we saw the sarcomatoid pattern, the other area we saw the papillary pattern, then we saw nice rhabdoid areas. We saw the clear cell component also. Yes, clear cell component were around 20%. So when we went through the literature, we didn't find any case with so many histopathological entities in one tumor, ma'am. Actually, the lady presented with a headache So, and then PET scan was done. There was a lesion in the cerebellum, and then when when workup of the patient, then the abdominal swelling, renal swelling was diagnosed, and then nephrectomy was done. And now the patient is undergoing a palliative therapy, ma'am. The patient is doing fine.
Very aggressive, no? It will be definitely behaving aggressively.
Aggressive, but the when CNS they haven't done any investigation. They've just taken that as it can't be anything else other than metastasis. That's what when we discussed with the onco department, that's what we were told. So the lady is undergoing palliative therapy.
Radiologists could have diagnosed whether it is MRI or CT would have helped you. No?
It is because of our histopathological distinct features in the same lesion, ma'am. We couldn't call it we can't call it a composite lesion or a collision tumor. And we had to, the name was renal cell carcinoma NOS, which includes all the different entities in one single tumor.
Under one heading.
Yes, ma'am. Yes, ma'am. Not many, only 2 or 3 components have been reported. So many components have not been reported in literature at all.
Yeah, very, very.
Yes, I think you should publish this.
Yes, ma'am. Yes, ma'am. Thank you. We had to break. It was Nalli, Dr. Sumitra's case, and it was tough to make a diagnosis with all this. We had to do a lot of.
I know. Since you have done a complete work, I think it is worth publishing.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. Thank you, ma'am. Can we, ma'am, if there are any questions, we can take up, or we can go on to the next case. Dr. Vinodini from Thiruvannamalai Medical College, are you ready?
Yes, ma'am.
Yeah, please. Please start screen sharing. Next, Dr. Vallalkani can be ready.
Am I audible, ma'am?
Yeah, you're audible. Your screen, you have to start screen sharing. We can see you over there. I think you're.
My screen is visible, ma'am?
Yeah, you are visible.
1 minute. Now, ma'am?
Yeah, start. We cannot see your PowerPoint. You're audible. You can start screen sharing. We can see your, you can start sharing your PPT.
Actually, I have shared my PPT, but I don't know why.
Yeah, we cannot see.
1 minute, ma'am.
Okay, come. What is it and watch? Yeah, I think start sharing, ma.
Good evening, madam. Suppose if it is late, she can present at the end, madam.
Yeah, Jayalakshmi.
Yes, madam. Good
evening, all of you, madam. But your PowerPoint is not there.
Jayalakshmi, how are you?
Madam, fine, madam. Thank you so much, madam. This is a simple case just brought from Thiruvannamalai.
It's nice. Nice.
Thank you so much, madam. I told the dean also that you are accommodating us also, and he is very happy. Aravind sir, he's also very happy, and you all have accommodated us. So he is also happy that she's presenting. So thank you.
Thank you. Okay, we'll wait. Dr. Vallalkani, if you're ready, you can start screen sharing, please.
Yes, ma'am.
Please. Yeah. Dr. Vinodini, just set it so that you can present after this case.
Yes, ma'am. Yes, ma'am.
Palalpani, you can start your PPT. PPT share பண்ணலாம்.
Yes, ma'am. Now I'm- Is it visible, ma'am?
Yeah, you can start. Welcome. Good evening.
Thank you. Good evening, ma'am. I'm Dr. Alkani from Savita Medical College. Okay. A 44-year-old female presented with complaints of lump in the right breast for past 4 months associated with pain. On examination, a 7x6 centimeter swelling was noted in the right breast. The clinical diagnosis was given as fibroadenoma. For her, the FNAC, true cut biopsy, then followed by excision biopsy was done. This is the FNAC. Here, the smears are cellular and shows branching papillary fronts and monolayered sheets and clusters of benign ductal epithelial cells. Here, this is the another area showing the smears. Okay, here the eye power where the benign ductal epithelial cells with interspersed myoepithelial cells were seen, and we could able to see a multinucleated giant cell here. Another section also smear also showed a multinucleated giant cell in a background of hemorrhage. So the report was given as category 2 benign according to the Yokohama System 2020, the feature suggestive of fibroadenoma and focal foreign body giant cell reaction. For her, the true cut biopsy was done, which showed the breast parenchyma with benign glands lined by bilayer epithelium and mononuclear cell infiltrates and the focal areas of foreign body giant cell reaction. So the report was given as benign breast disease with foreign body giant cell reaction. Then followed which the excision biopsy was done. And we received single globular mass measuring 8x5x4 centimeter. The cut surface showed gray white to gray brown areas and the random bits are partially embedded. And the multiple section studied shows sheets of tumor cells with interspersed giant cells and mononuclear cells scattered in the background. This section also shows sheets of tumor cells with the interspersed giant cells. The giant cells were osteoclast-like giant cells. Here in focal area, we could able to appreciate the necrosis and the osteoclast giant cells interspersed with the mononuclear cells. And the tumor cells were with scant to moderate eosinophilic cytoplasm and elongated to spindle shape with hyperchromatic and pleomorphic nuclei. Here, in this section, we could appreciate the cells are separated by pale eosinophilic extracellular material, which resembles osteoid. So, osteoid formation was also there. Okay, this is the section which shows the spindle cells, and here we could be able to appreciate the frequent mitosis in the sections. And in this section, the tumor cells are seen to invade the adipose tissue and extending up to the skeletal muscle bundles. Here, this area. And this section shows the areas of necrosis, and this section shows areas of lymphovascular invasion. Here, we could appreciate the cribriform variant of DCAS. This is the high power showing DCAS component. And we were able to see focal UDH component. And focal fibrocystic change were also noted. This is a high power showing the fibrocystic change with apocrine snouts. So IHC was done, which showed a triple negative. And for cytokeratin, it showed focal positivity. So a final diagnosis was made as metaplastic carcinoma breast with low-grade DCAS, and the tumor extends up to the margins of the excision specimen. At first, in the FNAC and the true cut biopsy, we thought it was a benign breast disease with foreign body giant cell reaction. But in the excision biopsy and the histopathology, we could come to the diagnosis of metaplastic carcinoma breast with low-grade DCAS component. And a few points about discussion. Metaplastic carcinoma breast is a heterogeneous group of invasive breast carcinoma, which are characterized by differentiation of the neoplastic epithelium towards squamous cells or mesenchymal looking elements including spindle, chondrite, or osseous cells. It was localized, that is, that it can affect any anatomical area of the breast. The clinical features are similar to those of ER-negative invasive breast carcinomas. However, the metaplastic carcinomas are more likely to present at an advanced stage. Most cases present with a palpable lump and are detected as a mass lesion on ultrasonography. Calcifications are uncommon. When present, they are often associated with DCAS or osseous differentiation. The incidence is 0.2 to 1% of the all IBCs, and the genes frequently mutated include TP53 and PIK3CA. In macroscopy, the tumors can present as well-circumscribed masses or with indistinct irregular borders, and the consurface appears pearly, whitish to grayish, and glistening areas in areas of squamous and chondrite metaplasia, and gritty and hard in areas of osseous metaplasia. The size ranges from 2 to more than 10 centimeters, and thorough sampling of the lesion is strongly advised. The metaplastic carcinomas can be monophasic, that is, with only one metaplastic component, or biphasic with 2 or more components. The 2 components can be of metaplastic histology, such as squamous or spindle cells with a mesenchymal or matrix producing component, or there can be only one metaplastic component and one adenocarcinoma component. On the basis of histological pattern, they are also classified into epithelial-only carcinomas, which include low-grade adenosquamous, high-grade adenosquamous, and pure squamous cell carcinomas, and pure sarcomatoid, which includes spindle cell or matrix-producing carcinomas, and biphasic epithelial and sarcomatoid carcinomas. They are usually triple negative and cytokeratin positive. These are my references.
Please, somebody is there. Please mute your. Yes, Dr. Valalkani, you can continue.
I finished, ma'am.
Okay. Thank you, Dr. Valalkani, for that slide. So it emphasizes the importance of the biopsy.
Yes. Thank you.
If there are no questions.
This as fibroadenoma with giant cells. 1 minute, Baler.
Yes, ma'am.
Why in FNAC you gave fibroadenoma with giant cells? Is it so common?
No, ma'am, it was uncommon, but we thought because usually fibroademas was clear, ma'am. We got clear-cut papillary fronds and monolayer sheets, but we could see adjacent only giant cells, ma'am.
The bare nuclei was evident. You are so confident of benign lesion only, or
yes,
it's area of FNAC sites may you would have missed this giants. I mean, other components.
Yes, ma'am. We received ultrasound.
Your focus was more in FNAC, more of fibroadenoma, isn't it?
Yes, ma'am. With the given the ultrasound guided FNAC smears, we got only benign lesions.
But your slide showed osseous areas also, and with the giant cells.
Yes, ma'am. In histopathology, we were able to see the osseous.
Well, but in 1985, I think Dr. Chitra was presented osteoclastic in a breast carcinoma ductal type with osteoclastic giant cells those days, before the entity of metaplastic carcinoma was coined. I think we presented Dr. Panch Madam in a Calcutta conference. I still remember this case, but now the entity is totally different and changed. And
so we also had a DD, ma'am, whether it could be a pure sarcomatous or the infiltrating ductal carcinoma with the osteoclast variant. But that was triple negative, and cytokeratin was showed positivity. So we thought we came to the conclusion of metaplastic carcinoma.
The matrix producing carcinoma.
Yes, ma'am.
Anyway, good.
Shall I close the session?
Oh, yeah, Valalkani, thank you for that case. Can we go on to the next presenter, Dr. Vinodini?
Yes, ma'am.
Final presentation. Yeah.
My screen visible, ma'am?
Yeah.
Sorry for the delay, ma'am.
Yeah, it's okay.
Good evening, one and all. I thank Professor Valarmadi ma'am, Tamil Nadu IAPM chapter, all professors and my beloved HOD Dr. N. Jayalakshmi ma'am for providing me this opportunity to present the first case in City Pathologist Meet. So going on with the case, we had a 32-year-old female, P3L3, presented with complaints of lower abdominal pain on and off for 10 days and was admitted in the emergency ward with sudden onset of severe abdominal pain. The imaging studies revealed a diagnosis of right complex ovarian cyst and an enlarged left ovary. And CA-125 level were 28.7 units. We received a gross specimen labeled as right ovary, which showed a large cystic mass measuring 15 cross 11 cross 6 centimeters. The external surface appeared gray-white, bosselated, with a small nodule measuring 1 cross 1 centimeter on the surface of the complex cyst. The cut surface let out 20 ml of hemorrhagic fluid and showed both solid and multiple cystic areas. On further cut surface of the cystic area showed a gray-white to gray-tan nodule measuring 5 cross 3 centimeters, which was firm in consistency. And the specimen from the other side ovary, which was an ovarian biopsy, left ovarian biopsy, it measured 3 cross 2 cross 1 centimeter. The external surface appeared gray-white and nodular, and cut surface showed multiple tiny gray-white solid areas and focal gray-black areas. We also received peritoneal and omental biopsy, and the peritoneal and omental biopsy was unremarkable. And coming to the microscopy, this is a scanner view of the right ovary, which we received as right complex ovarian cyst, which showed a ovarian capsule. And underlying the ovarian capsule, the ovarian cortex had a thick fibrotic stroma infiltrated by the malignant neoplastic cells. These malignant neoplastic cells was arranged in irregular groups, diffuse sheets, glands, and tubular pattern. And this is the low power and high power view, which showed us the typical glandular pattern surrounded by the fibrous stroma. And this is the high power view, which showed us the signature cells characterized by large hyperchromatic, irregular, peripherally placed nucleus, and the cytoplasm were clear, it was clear and vacuolated. And these signature cells were arranged in clusters and singles and was entangled in a fibrotic stroma. We also visualized areas of hemorrhage, necrosis, and atypical mitosis was also seen, accounting for 20 per high power field. And this was taken from the nodule on the surface of the right ovary, which also showed similar morphology, but with capsular infiltration. The biopsy specimen, which was from the left ovary, also showed the similar ovarian parenchyma with a thick fibrotic stroma and also infiltration by the malignant neoplastic cells. This is the hyper view showing the glands and tubular pattern in the cellular stroma. And one more hyper view, which shows us the signaturing cells in singles and clusters entangled in a fibrotic stroma with the same morphology. So we did a PIS stain, which showed an intense magenta colored cytoplasmic positivity in these signaturing cells, positive for neutral mucin. The omental biopsy and peritoneal biopsy was unremarkable. And with a summary of 32-year female with lower abdominal pain, pre-op diagnosis of right complex ovarian cyst and enlarged left ovary, with the gross and microscopy and special stain PAS positive, we have given the diagnosis of possibility of metastatic carcinomatous deposits, both ovary, Krukenberg tumor, suggested further clinical evaluation to rule out primary from GIT, stomach, colon, appendix. So following after the diagnosis was made, it was subsequently informed to the OG and the surgery professors, and the patient was planned for an OGD-scopy. And for our surprise, the OGD-scopy revealed a 4 cross 3 centimeter ulceroproliferative growth in pylorus. So by a time span of 7 days, the biopsy was taken and sent, and we received a multiple gray-brown soft tissue fragments amounting to 0.5 cc in aggregate, all were embedded. So this is a microscopy of the gastric biopsy we received, which showed an ulcerated mucosa, gastric foveolae, and the lamina propria being infiltrated by the malignant neoplastic cells. And the high power view showing signaturing cells with a similar morphology, which infiltrates the muscularis mucosae. This is a special stain, which also showed positive thick magenta colored cytoplasmic positivity. So the report was dispatched as poorly differentiated adenocarcinoma, poorly cohesive type. So coming to the discussion part of the part, so as we received the specimen, gross specimen, the differential diagnosis we had for the solid and cystic tumors were surface epithelial tumors, high-grade serous, mucinous, endometrioid, or germ cell tumors with the age in consideration, teratoma and yolk sac tumor, and sex-cord stromal tumors like granulosa cell tumor, juvenile type. And after identifying both the ovaries involved by the malignant cells, the differential diagnosis was tapered down to high-grade serous carcinoma, mucinous adenocarcinoma, endometrioid adenocarcinoma, germ cell tumors, Krukenberg or metastatic tumors. And all the differential diagnosis was tapered with the morphological pictures. We ruled out just this germinoma with the because of the absence of diffuse sheets of large polygonal cells surrounded by the fibrous septae, infiltrated by lymphoplasmacytic infiltrate. So by the absence of all this germinoma was ruled out. And we also ruled out juvenile granulosa cell tumor by the absence of multiple follicular structure filled with basophilic secretions and the cell morphology of abundant eosinophilic cytoplasm and occasional grooved nucleus. And the endometrioid adenocarcinoma was ruled out by the absence of back-to-back glandular arrangement and high-grade nuclear atypia. And the high-grade serous carcinoma was ruled out by the absence of typical papillary arrangement of neoplastic cells and absence of samoma bodies. Being the periphery institute, a government Tiruvannamalai Medical College, we did not have IHCs. And so it was very challenging for us to diagnose a Krukenberg tumor with the morphology and also with the to search for the primary. A few notes on the immunohistochemistry. The primary tumors for the Krukenberg can be from stomach, colon, appendix, breast, and ovary. And the ovary mets from the gastric adenocarcinoma has a IHC positive of CK7 and CK20 positive. And from the intestinal adenocarcinoma, it is strong and diffuse cytoplasmic CK20 positive. And the appendiceal carcinoma, it is CK20 positive. And this is a summary of the IHC markers, which helps us to identify the primary source of the Krukenberg tumor. And the other differentials we had in our mind was signet ring stromal tumors, sclerosing stromal cell tumor, and clear cell adenocarcinoma. Signet ring stromal tumors are benign tumors, unilateral tumors, and they stain positive for vimentin and negative for cytokeratin. And sclerosing stromal tumors, they are PAS positive. They have hypo and hypercellular areas. And clear cell adenocarcinoma, they have a typical papillary tubulocystic pattern with hobnail cells. And also they contain glycogen and PAS positive. And the article reference was taken for the median overall surveillance among the patients with Krukenberg tumor. It was found to be 11 months for the gastric adenocarcinomas and 21.5, 31, and 19.5 months for with respect to the primary, with the respective value of p-value less than 0.001. And this case was presented for its rarity, younger age of presentation, and bilateral involvement, and challenges in diagnosing without the IHC markers. And the primary source was identified by a time span of 7 days. These are my references. Thank you.
Thank you, Dr. Vinodini, and thank you, Dr. Jayalakshmi, for encouraging Dr. Vinodini to present the case. That was a well-presented case.
Thank you so much, madam. Thank you so much for giving us an opportunity. This is actually a straightforward case, though it is a straightforward case we just brought into the forum because we don't have IHC, for our government colleges in the periphery. So the PAS was brought out very well here. So we came out with a madam. Thank you so much for encouraging us. So that is
a good start.
Yes, thank you so much. Thank you so much, madam. Thank you all, madam. Patient is under treatment actually. Patient has gone to Jitmer. They have referred, but she has gone to see her, and the patient is on treatment, cytoreductive surgery followed by chemotherapy. The patient is undergoing. Such a young lady with the 3 children, and husband is actually praying for that, and now she is under treatment, madam. So that is a case of that patient.
Thank you, Dr. Jayalakshmi.
Thank you so much, madam.
Then, ma'am, can we? There are no questions, so that was that comes to the final phase of the presentation. So we had wonderful cases today, and ma'am, Sita ma'am, are you there? Thank you, Sita ma'am, and thank you everybody, ma'am, for all your inputs and all the congratulations to all the presenters, and thank you so much. Thank you.
Thank you, Valer.
Thank you, ma'am. Thank you, Raji ma'am irukangla. Thank you, Raj Lakshmi ma'am, and thank you, Jamila ma'am.
Thank you, madam.
Thank you. Thank you.
என்ன சொன்னீங்க? நான் ஒண்ணு பேசிட்டு இருக்க போதுதான் இதுவா அதுவா ஐடியா எல்லாம் கொடுக்குறீங்களேங்க. நம்ம ஓபன்ல இருக்கு. லாஸ்ட் ரவுண்ட் அப் பண்ணியாச்சு, அன்மியூட் பண்ணியாச்சு. நான் பேசணும்ல அவங்க பண்ணீங்க, அதுக்குதான் பேசுறதுக்கு தான் வச்சிருக்கு. சரி அது பரவாயில்ல. இப்ப என்னது என்ன வாங்க சொன்னீங்க? இல்ல இவங்க என்ன சாப்பிட சொல்றாங்க வாங்கறதுக்கு? என்ன வாங்க சொல்றாங்க? அதான் சொல்றேன் நானும். சுட வச்சுட்டு கொஞ்சம் பண்ணி கொடுத்துடலாம். சொல்லுங்க. என்னத்த அது பண்ண முடியாதுப்பா. They won't do valuables. என்னத்த valuables they will not do. அப்படியே ஆமா, ரிஸ்கி. என்னத்த அதான் வருமா ஈவினிங் டிராபிக் ஆயிடுச்சு. நைட் மெதுவா போயிட்டு முதல்ல போய் சாப்பிடுங்க. பாவம் நீங்க சாப்பிடாமலே வரீங்க. உங்களுக்கு பாவம் பட்னியா கடந்து இருக்கணும். நீங்க தானே வச்சீங்க அவ்வளவு அரிசி. அப்புறம் நான் எல்லாத்துக்கும் நடுவுல ஒழுங்கா உங்க 2 பேருக்கும் ஸ்ட்ரெயினோ குக்கர் வாங்கி